Hi, it is 10 a.m. This is the time we're supposed to start. I'm seeing people come on in. Welcome to MiHIN's The Download. Thank you so much for being here. Now that you are here, please be here with us. Take this time to focus and concentrate and dig in. We have a really, really important, not that they're all not important, but we have a very special guest speaker. So I want to get through my spiel really fast. It is 10:01. So Kate, I think we should start. You are here at MiHIN's The Download. Here's our agenda for today. Joanne Jarvie. Hi, I am the Senior Director of Outreach and Market Communications for MiHIN. And I'm going to do a quick welcome spiel. And then we have Sarah Peliani, Masters of Public Health from Columbia University and Senior Research Associate at NCQA. What's NCQA? I've heard about this NCQA. Why is NCQA important in our ecosystem? You're going to learn. She's also going to talk about NCQA's new social screening and intervention measure. After that, Sarah has to go at 11, so we've got to get her. After that, our Mike Taylor, who is a product marketing manager for MiHIN, will go into MiHIN's SDOH, Social Determinants of Health, Social Needs Screening use case. And then we're going to get to some questions. Actually, we should do some questions with Sarah, and then we're going to talk, and then we're going to come back for the next one. All right, let's go. Thank you. So, welcome. What's MiHIN? MiHIN is the state of Michigan's designated entity for health information exchange. Health information exchange isn't something that just happens. It's not, unlike every other sector, people's private and intimate information and data does not just flow to everyone. There are guide rails, there are legalities, there is governance that needs to be happening at all times around what information is needed by what people to make what decisions to make people more, just make people better, to make people healthy, to create care teams around the people that need it the most. We are a nonprofit. We are a statewide digital infrastructure. We are a neutral steward of data, an unbiased data trustee. MiHIN doesn't make the rules. MiHIN follows the rules. MiHIN makes it technically possible. And guess what? By the way, let's talk about technically possible. Technical infrastructure is easy compared to human infrastructure. Setting up wires or setting up systems to talk to one another is not even as difficult as setting up two sectors to understand how they each do business and meet in the middle. I am here. When you reach out to me, you will get answers about human infrastructure. There's a whole bunch, probably 150 people at MiHIN who are better to talk about the technical infrastructure. We are focused here mostly on human infrastructure and very high level technical infrastructure. Technology is a tool. It is supposed to support human beings. Let's not forget that focus. Next slide, please. The goals of health information exchange broadly are to make people better. We are trying to use information at the point of care and data over large swaths of populations to help predict, react to things like a pandemic. We are hoping for better healthcare outcomes. We are hoping to reduce burdens. We are hoping to reduce healthcare costs. These are our aims. This is why we do what we do, why we work to technically, legally, privately, and securely exchange people's health information. Next slide, please. MiHIN works within technology infrastructure, sure, but also there are data standards, right? There are basically when systems talk to one another, they have to be talking in the same language or having a system in the middle that translates that information so that it talks the same language. That's the data standards, and also legal guide rails for where information on any one human being can be delivered. and be exchanged? What purposes can it be exchanged for? These are the areas that MiHIN is constantly trying to figure out for our state, for our citizens, for the people that need healthcare, for people that need help. Next slide, please. Really quick, I wanted to remind everybody about how we work under HIPAA's clear chain of trust. Okay, and we can get back to this. We can do another MiHIN 101. We can dig in, but let's remember that MiHIN works legally under the bounds of HIPAA. And we work from getting information from covered entities through trusted data sharing organizations with business associate agreements to MiHIN, through business associates back to covered entities. This will come up. If you don't understand it, let's dig into it another time. But I just wanted to remind you of the world in which we are today, currently exchanging information legally. Thank you. So now it is my very real pleasure to introduce our guest, Sarah Pelliani. Sarah works for NCQA. She has her master's in public health. She has been so gracious. I've been like stalking her. She's going to answer some questions for us. She's going to dig into social needs screenings. And at the end of your presentation, Sarah, I really want to give people the opportunity to connect directly with you. Your questions that you sent in to us have made their way to her. And so if we don't answer your questions, ask them again. If you have a burning question, interrupt. I mean, I'm an interrupter. Sometimes you just can't help yourself. I don't want to make it hard for you to engage. You can also use the chat. Sarah Pelliani, I'm done with it. You are the star. Please, over to you.
Thanks so much, Joanne. And just to confirm, can you see the slide deck that I'm sharing?
HEDIS 101 and social needs screening. We sure can.
Perfect. All right. Well, thanks everyone for joining today. Thanks to the MiHIN team for inviting me here today. I'm really looking forward to the discussion today. And as Joanne mentioned, please do feel free to interrupt me with any questions throughout. My name's Sarah Pelliani. I'm a senior research associate with the National Committee for Quality Assurance, which I'll refer to as NCQA throughout today. I work in our performance measurement department. So I support measure development work in a number of areas focused mostly around health equity, social determinants of health, and disparity-sensitive clinical topic areas. So today I am going to share a little bit about NCQA and HEDIS quality measurement generally, and then share some details about a new social need measure which has been developed to assess social need screening and intervention among health plans. Agenda for today, during my time at least, I'll start with some general information about HEDIS, how HEDIS measures are used for accountability. Then I'll provide an overview of our new social needs measure. And finally, we'll hopefully end with time for questions before I pass it back to the MiHIN team. So to start with, who is NCQA? What do we do? And there's probably sort of a diverse array of familiarity with NCQA, so this might be a review for some of you, but for those who haven't come across NCQA before, NCQA is a healthcare quality organization dedicated to improving the quality of our health system through the development and implementation of evidence-based standards, measures, programs, and accreditation. Our mission is simple, though perhaps not easy, to improve the quality of healthcare in this country. And we pursue that through the levers of measurement, transparency, and accountability. Measurement meaning assessing what the current state of healthcare quality performance is. Transparency meaning making that performance information available to healthcare entities, policymakers, patients, the public. And accountability through enabling us to hold the health system accountable for quality performance. We work towards all of this with sort of the fundamental belief that we can't have quality without equity, and that the pursuit of healthcare quality really can't be divorced from the pursuit of health equity. So our work is operationalized in sort of a variety of ways at different levels of the healthcare system. We have sort of clinician level recognition programs like patient-centered medical home, which some may be familiar with, a set of standards for clinicians and practices to meet, which demonstrate patient-centered care. Working with clients to develop and implement custom quality solutions, data analytics and information technology. And finally, through health plan level quality measurement and accreditation, which some may be sort of most familiar with of our work. So NCQA maintains what we call the Healthcare Effectiveness Data and Information Set, HEDIS. And we accredit health plans who meet a certain set of standards of quality. Today, I'm really going to be focusing mostly on the health plan quality measurement bucket of our work here, HEDIS, and how HEDIS is used for measurement, transparency, and accountability, particularly as it relates to social determinants of health and health equity. So for those who aren't familiar with HEDIS, by way of brief background, HEDIS, the Healthcare Effectiveness Data and Information Set, is a set of performance measures used by a large percentage of health plans, and it assesses performance across multiple dimensions of health, like preventive care, chronic care management, behavioral health, care coordination, appropriateness of care. So HEDIS measures really allow for comparison of how well plans are delivering care to their members across these domains to help understand which plans are delivering high quality care compared to others and vice versa. And given our understanding of quality as fundamentally tied to equity, NCQA has really made it a priority to invest in advancing health equity across all of these domains, which includes both sort of direct measurement of disparities in care across these clinical services and outcomes, as well as measurement of how well plans are beginning to address the social drivers of health, which can contribute to disparities and inequities. Now, before I get into some of the specifics of this social needs measure, which is the subject of today's discussion, I want to just talk a little bit about the mechanics of a HEDIS measure and how they're used for transparency and accountability. So what is a HEDIS measure and how does it evaluate healthcare quality? HEDIS measure is sort of a metric that's used to calculate the extent to which a recommended service, generally that which is evidence-based and guideline supported, is being delivered to a health plan's membership. HEDIS measures can also assess outcomes and events. But generally, HEDIS measures include the components that you see here in order to kind of enable this assessment. They include an initial population, which is generally a broad population of interest to a measure's focus. This might include sort of age criteria, a type of insurance plan, any diagnoses of interest to the measure. They include exclusions. So this is who is excluded from the calculation of this metric. Who are the individuals who maybe meet that broad initial population criteria, but have a particular characteristic that make them ineligible for the service being assessed in the measure. For example, if hypothetically a measure is looking at diabetic foot exam, perhaps the measure would exclude individuals who had undergone bilateral amputation and were ineligible for that exam. Measures include a denominator, which is the resulting population. This is everyone in the initial population minus those who we have excluded. And this is the population among which we look to see, did they meet the measure criteria? Did they get the service? Did they have the outcome? And finally, the numerator, which is the process, condition, event, or outcome that satisfies the measure's intent. So the numerator and denominator are used to calculate a measure performance rate. And this is usually going to be expressed as a percentage. So the percentage of a plan's membership who should have received a service that did receive that service. So that's sort of the mechanics of a HEDIS measure and how HEDIS measures work to assess quality. Now, how are HEDIS measures reported? Where does the data actually come from to feed into these measures? There are a few different methods of reporting HEDIS measures. And I have them listed here. So some measures are reported using what we call the administrative method. And these are measures that typically rely on enrollment claims or encounter data. Some measures are reported using what we call the hybrid method, which are measures that rely on administrative data and manual record review. Some are reported using survey data, CAHPS, Health Outcomes Survey. And then we have measures that are reported using what we call the electronic clinical data systems method. And these are measures that rely on electronic data that may live in various electronic systems that you see here. And increasingly, we are moving towards digitalization and greater reliance on this electronic clinical data. So you're seeing more HEDIS measures reported through this electronic clinical data systems method. All right, so we've talked about what a HEDIS measure is, how it evaluates quality, but how are they actually used to drive transparency and accountability and improvement in quality? Measurement for measurement's sake can only go so far. So the transparency and accountability piece is really how ultimately change is incentivized and quality is improved over time. So HEDIS measures enable transparency and accountability in a few ways, and this list is not exhaustive by any means, but just a few examples. So at some point in their life cycle, most HEDIS measures will become publicly reported, which means that a health plan's performance results on a given measure is available for others to see and compare against other plans and against benchmarks. HEDIS measures may also be used in scoring methodology for health plan ratings and may be required as a part of required to be reported as a part of accreditation, for example, or may be included in certain recognition or certification programs. And lastly, these measures also become used sort of beyond NCQA's programs. So HEDIS measures are used across a broad range of, for example, CMS quality incentive programs, for example, the quality payment program, quality rating system, star ratings, many of these other public programs. So through these and through other transparency and accountability mechanisms, HEDIS measures sort of serve to catalyze health plan investment in high priority health concerns of measures. Of members, excuse me. And so when we think about how HEDIS measures can be used through mechanisms like these to catalyze change, it becomes really important to ensure that we're measuring the right things in a way that is in service of intentionally reducing disparities and promoting equity. So all that said, with measures used in all these various programs with incentives to improve performance, accountable entities, health plans in the case of a HEDIS measure have therefore a responsibility and are incentivized to invest in quality improvement efforts. They're incentivized to invest in exchanging data in support of high quality care, improving the infrastructure necessary to deliver high quality, equitable care, working to improve desired outcomes, and overall be accountable for delivering equitable care and services to members. So the intended output of all of this is improved quality, equity, and value in our healthcare system. All right. So having provided some of that background on HEDIS, I'm now going to provide a quick primer on how HEDIS is approaching social needs quality measurement, with a specific focus on our new social needs screening and intervention measure. All right, so while I have spoken broadly about our commitment to equity, what are we specifically doing? So specifically, our goals to support advancement of equity in HEDIS include bringing transparency to existing inequities in care, promoting inclusive approaches to measurement so that there aren't certain populations that are being left out of or minimized in measurement, moving beyond just measurement of those clinical factors, but also beginning to address the social factors that contribute to outcomes, and eventually to get to a point where HEDIS measures are used to directly incentivize disparities reduction and equity through equity-focused benchmarks and performance scoring. That piece in the red box is really the subject of today's discussion, but at the end, I'll just touch on some of the other work we have going on in some of these other areas. So first, why address social needs? And I realize I probably don't need to spend a lot of time making the case here to this audience, but I do think it's important to contextualize why NCQA thinks it's important to measure this and why we think it's important that health plans are focused on this. Well, we know that health is impacted by more than just clinical factors and behaviors, that a substantial contribution is coming from environmental, social, and economic factors, which influence the level of opportunity one has to pursue and achieve health, however they define it. So if we want to be improving health outcomes, we need to be thinking about social factors as well. And plans have a role to play in really figuring out what social needs are contributing to the health access and outcomes among their members and providing supports or sort of linking patients to the supports needed to address those social needs. And social factors don't just drive individual outcomes, they're also driving the disparities in care and inequitable outcomes that we see across the population, because the burden of these social, economic, and environmental risk factors are not experienced equitably across the population. So if we want to earnestly pursue health equity and dismantle longstanding disparities, we need to be thinking about addressing social needs. So for those reasons, NCQA set out to develop a new HEDIS measure that is focused on addressing member social needs. Really quickly, in developing all new measures, we follow a measure development process, which you see here. We start by selecting a high priority measurement topic, in this case, social needs. We conduct research development and testing to bring that new measure concept to life. We post new measures to public comment to collect feedback before actually publishing the new measure in HEDIS. So the new measure I'm talking about today was developed and tested last year, was posted for public comment in the spring of this year, and was officially published as a new measure this past August in the measurement year 2023 HEDIS volume. So 2023 will be this measure's first year in use with plans, meaning the first year that plans are actually collecting data and reporting data on this measure. The measure focuses on 3 social needs: food, housing, and transportation. Food, obviously, relating to access to food that's adequate in quantity, quality, and is culturally acceptable, aligned with the patient's preferences. Housing, composed of sort of subdomains of housing instability and homelessness and inadequate housing. Instability relating to sort of financial difficulties with obtaining and maintaining housing, and housing adequacy dealing with sort of housing quality, habitability. And then finally, transportation, referring to obviously access to transportation to meet medical and non-medical needs. Here is the measure specification. So these are sort of the details of exactly what this measure is assessing. It assesses the percentage of members who during the measurement period were screened at least once for unmet food, housing, and transportation needs using a pre-specified instrument. And if screened positive, received a corresponding intervention. The measure has 6 indicators, 1 each for screening and intervention for each of the 3 social needs. The measure will be reported by commercial Medicare and Medicaid plans using electronic clinical data systems, which I'll talk more about momentarily. Individuals are excluded from the measure if they are in hospice, enrolled in institutional special needs plans, or residing in long-term care institutions. And the measure is specified for all age ranges, but rates are reported stratified by age among children, adults, and older adults. So I've mentioned electronic clinical data systems as a reporting method, but just to share a little bit more in detail about the types of data that are included for ECDS reported measures. ECDS is a structured method to collect and report electronic clinical data for HEDIS quality measurement. For reporting of ECDS measures, plans submit each measure component, so the numerator, denominator, exclusions, et cetera, by the data source used to access the data. And approved or allowed data sources are categorized really into 4 main types: electronic health records, health information exchanges, case management systems, and then administrative data systems. So the data for these types of measures can live in and be accessed using any of these types of electronic systems. Plans just need to access and report the measure components to us based on the type of electronic system that the data came from. So I want to touch on data standards. So as a measure that is reported using electronic data, it was really important that we develop this in alignment with the data standards to ensure feasibility and that the data elements actually exist to support this measure. So we've aligned this new measure with the standards coming out of the Gravity Project. I know many of you on the call may be familiar with the Gravity Project already, but for those who are less familiar, the Gravity Project is a data standards entity that is developing consensus-based standards for documentation and exchange of social determinants of health data in healthcare. So Gravity brings together stakeholders and subject matter experts from a broad range of fields and disciplines to identify the SDOH, social determinants of health data elements that need to be able to be captured and exchanged in electronic data, and then develops the standardized terminology necessary to do so. So Gravity has done a tremendous amount of work developing electronic terminology for documentation of social need screening, diagnosis, goal setting, and intervention for a broad range of social need domains, including food, housing, and transportation. So these are the standards to which this measure was really anchored. So getting into some of the nitty-gritty details of this measure, starting with the screening indicators. So there are 3 screening indicators, one for food, housing, and transportation. The denominator for those 3 screening indicators is health plan members of any age, excluding those who meet the exclusion criteria I talked about. And the numerator assesses members in the denominator who have at least one documented result on a screening instrument for food, housing, and transportation, respectively. Screenings count towards the numerator if they were conducted using one of a list of pre-specified screening instruments you see here. So the Accountable Health Communities, Health-Related Social Needs Screening Tool, Health Leads, Prepare, Hunger Vital Sign, etc. These are all screening instruments that have been sort of approved by the Gravity Project data standards for these social need domains. Now I'll move on to the intervention indicators of the measure. The intervention indicators assess among the subset of members from the screening numerators, those who screen positive for food, housing, or transportation, the percent who receive a corresponding intervention within 30 days of the first positive screen during the measurement year. So the interventions included here are categorized into 8 types, which you see here: assessment, assistance, coordination, counseling, education, evaluation of eligibility, provision, and referral. So one of these intervention types has to be implemented within 30 days for those who screen positive in order to meet the criteria for the intervention indicators. And here are some examples of what those specific interventions look like. So assistance might include assistance with application to a homelessness prevention program, coordination of care plan, education about an area agency on aging program, referral to a program, or actual provision of meals. So what does this look like? Where is the data coming from for this measure? How can plans, what types of data can plans use to report this measure? And this is a very simplistic schematic. There's a lot of additional complexity that exists here, obviously. But for the purposes of reporting this measure, screening and intervention data could be coming from a variety of sources. It doesn't necessarily originate sort of at the health plan or within the health plan. So it could be coming from clinician sites. It could be coming from a health risk assessment in the case of a special needs plan. It could be coming from a community organization. It could be coming from a health information exchange. So all of this data is sort of coming from ECDS, electronic clinical data systems approved sources can sort of feed into the data that ultimately gets reported for SNSE measure performance. Briefly to share just a little bit about what we found when we tested this measure during development, we found that screening rates were pretty low across the board. Highest rates we saw were for food insecurity in the Medicare product line, very low rates for the other domains, particularly in the Medicaid and commercial product lines. Intervention rates were comparably high, so suggesting that plans are maybe doing a better job of, or a good job of linking patients to resources once a need is identified, which suggests that if screening rates are to improve over time, we may see a substantial increase in the number of members that are getting linked to needed resources. Some of sort of the qualitative findings from testing and things that we've heard from stakeholders throughout development that we're keeping in mind as we evolve this measure. Ensuring standardization doesn't come at the expense of culturally and linguistically appropriate services. You know, we want to mitigate this by ensuring that though we have limited this measure to a list of standardized instruments, that this doesn't preclude organizations from making cultural and linguistic adaptations to screening instruments. Acknowledging sort of the currently limited linkage between, you know, system and data system integration between health system and community entities. We've heard from both plans and community organizations that sort of the currently limited level of integration and challenges that poses to information sharing about patients who are moving between the health system and the community can be a challenge. So for that reason, among others, this first version of the measure doesn't require closing of the referral loop, but we are interested in and sort of committed to thinking through how we can get there eventually. And then, of course, acknowledging the variation in community resource availability that exists, which is, you know, an ongoing challenge and consideration. In this first version of the measure, we've applied a very broad definition of intervention, which encompasses activities that may rely on community resources and those which may be reasonably implemented by the plan themselves. But we're, you know, interested in and committed to continuing to explore measurement strategies which best address this variability. Just to share a little bit about the timeline here before I wrap up, this measure was published this past August. 2023 will be the first year for which health plans collect data about which they report. In spring of 2024, plans will report their first year of data for this measure, after which we'll conduct some analysis we call first year analysis to evaluate any changes that we need to make to the measure. And just to end with a few words on our sort of broader equity related work, social needs measurement is one part of this, and we expect to continue to sort of expand on this work with exploring additional domains of social need in future measurement years. For example, at the moment we're doing some development work in the social connection, loneliness, social isolation space. But beyond that, we have ongoing work related to looking at disparities in care by race and ethnicity, addressing gender inclusivity in measurement, making sure that transgender and gender diverse individuals are included in HEDIS measurement appropriately, and future work looking at additional domains of equity, for example, equity for members with disabilities. So with that, I will open it up for questions from the audience and have listed my email here. So please, everyone, feel free to follow up with me afterwards with additional questions. Let me see.
So we have 116 people on the call. Sarah, thank you for that. That was a lot. I mean, you know, and I would love to open it up. I know that we have Sarah here. She is, this is a get. So please come off mute, come into chat and let's ask some questions or send me the questions and I can ask. I know there were, I had some questions beforehand, Sarah, if I may, just to start it off.
Sure.
About like when you're using, can people use different screenings or different screening tools to get to the questions you need for the measure? Do they have to ask those specific questions or are there a range of tools, or, you know, there's the prepare tool, there's all kinds of different screening tools. Can anybody use their own, or how does it work?
So there is a list of screening instruments that can be used to meet the measure requirement. So each social need domain, food, housing, transportation, has a list of screening instruments that can be used. And these are instruments that have been approved by the Gravity Project as sort of appropriate for those domains, and which have standardized terminology available that can be used to document the results of those screenings. And plans can sort of mix and match. So you, for example, if you have, many organizations have developed sort of their own screening instruments that are composed of various validated items. So you might have a question from the hunger vital sign for food. You might have a question from the prepare for housing. You might have a question from the prepare also for transportation. Those would all constitute appropriate screenings for the purposes of the measure.
I hope that helps. There are questions in the chat. One is, wouldn't plans just have to indicate that social needs are not a benefit, like in their plans? So if it's not reported, there's no benefit. Like, is there a way for plans to just not deal with this?
So this gets at sort of the accountability piece of HEDIS measures, because, you know, there's no one has to report. NCQA can't require anyone to report HEDIS measures, right? The accountability comes in when measures are used in various programs, and when, for example, state may require reporting of certain HEDIS measures for MCOs or something. So it sort of depends on where this measure is used in what programs. By itself, no one, a plan is not required to report this HEDIS measure. Once it is used in programs, if it were eventually to be pulled into, for example, Medicare STARS ratings, then it would be required to be reported as a part of that. But that sort of gets into the accountability piece, that a measure for measure's sake doesn't necessarily get to that transparency and accountability piece. It's once it sort of gets pulled into programs and used for incentives.
Right.
See lots of questions coming in.
Do you want me to read them to you? You want to read them? How do you want to do it?
Let's see. I can kind of go through these. So, can health plans count these screens conducted by their provider network? Yes. So the screening itself doesn't have to originate or be implemented at the plan level. The plan can obtain this data from providers within their network, from community organizations, other entities that are conducting the screenings. And part of the intent of the electronic clinical data systems reporting method is to facilitate that. So, we want to be able to account for screenings and services that are being conducted at by these various entities, and ultimately reduce duplication and prevent having to implement multiple screenings and all of that. So part of the intent of this ECDS reporting method is to facilitate that data exchange between entities. So yes, screens conducted by the provider network would count. All right. Let's see.
So there's a H. Kramer has this question about counting, right? Counting patients who have indicated they do not want intervention. And I just want to take 2 seconds to say that I come to MiHIN from a community-based organization, and what we found, and I'm wondering how this has come up like at NCQA, we found over and over again that the person that is asking another person if they need help matters, right? So somebody could say, somebody could screen positive, right? Say, yeah, I need help. And then somebody could say, do you want my help? And that person could say, I'm not interested in getting help from you, right? So the first question is, do you count patients? How do you, what do you do with patients who have indicated that there's needs, but that they're not interested in getting help, at least from the person or entity that asked them?
Yeah, I think this is such an important question because, social needs are defined by a patient's preferences and priorities. So there's a couple of parts to this. The first thing I'll say is that there isn't yet a standardized terminology available to document declination of social need screening or declination of social need terminology or social need intervention. So that is a need in the data standards space. And I do know that this is something that Gravity Project and others are working on as sort of an identified need. For the purposes of how this is handled in the measure, this is a part of the reason why we did not implement a closed loop referral requirement or sort of confirmation of receipt of service requirement, because absent the ability to sort of identify where patients have declined interventions, we did not want to require that a plan confirm that an intervention was implemented within that time frame. So that's sort of how it's accounted for in the measure, which is that we don't require that there's confirmation that a patient actually went through with a referral or got served. That said, there's obviously a huge benefit. The purpose of all of this is to make sure that patients who want interventions and want help do get their needs met. So as we look towards moving towards measurement of sort of the next step in the referral pathway, it will be really important for us to specifically account for individuals who decline.
Great. Thank you. Right. So I think this kind of fits into it. Is there a code for assessed and no needs identified? And does that meet your measure? Did we do all that we had to do there?
Yeah. So currently there is no code for assessed and no needs identified. This is there is interest by Gravity Project and other measurement entities to see a code like this created that could be used, for example, to identify, assessed for food insecurity, no need identified, no follow-up required, et cetera, for each of the social needs. So that doesn't exist yet. If and when it does exist, it could be reflected in the measure. The challenge is that codes like that are typically not tied to specific instruments. They're not tied to they don't have sort of standards or requirements around which they can be used. And so it becomes a measurement issue when, we're trying to assess that a screening was conducted using a tool that has met some sort of minimum standard for validity, appropriateness, et cetera. So that's a long answer to that. The short answer is no, a code like that does not exist yet. But if and when it does exist, we would certainly thoroughly vet it and make a determination about how it would fit into the measure.
So, right. So this is just the beginning of what will be a long, important journey, I think. And you guys are learning, right? You can't start out perfect, even though like I did, not everybody can start out perfect. Question from Robin and York. Does NCQA's strategy fit into the CNMI initiative with value-based payments?
Yeah, so I think CMMI, Center for Medicare and Medicaid Innovation Initiative with value-based payments. So one of the CMMI models is the Accountable Health Communities model. And so coming out of the AHC is the Accountable Communities for Health-Related Social Needs Screening Tool, which is included as a part of our measure and an allowed screening instrument. So I think there's a lot of alignment between some of the SDOH related CMMI models like AHC and this measure for sure.
Let's see what else. Oh, so this is kind of interesting. And this is something that I've always wondered about NCQA. So Sean Baker wrote, like, will the results, right, be publicized throughout 2023 or not until after 2023 ends? So he's asking about when, right? And I guess so there's a when question. And then for me, there's sort of like, where does any one person on the street go to understand like how their plan scores, or like what does a plan score mean for any one consumer? Like, how do we even know? I don't even remember hearing about this before I sort of started doing this work. And it seems like, I don't know, is that something that, does NCQA want to be like something that people talk about at dinner? Like, I mean, how does it meet the person?
Yeah, so I'll talk about like the timing and then sort of dissemination, I guess, how I'd call that second. So timing piece is 2023 is the first what we call measurement year, which is like the calendar year during which we are evaluating health plans' performance, that they're collecting data and about which they're reporting. Plans will report that data to us in the spring of the following year. So now we're in spring 2024. We don't just publicly report that first year of data. We look at that first year of data and we bring it through our sort of expert committees and say, you know, should this be publicly reported? Or is there something that, some reason why we want to maybe hold back on reporting this information publicly because we need to make a change to the measure or something. So at the earliest, we would see performance information publicly reported, you know, after that first year analysis process. So this is now, you know, 2024 is when we've conducted first year analysis. How this information sort of gets to consumers is, for example, I've alluded to some HEDIS measures are used in CMS's star ratings. So, you know, star ratings is the rating system that is used to evaluate Medicare Advantage plans, and consumers, you know, when they're shopping for MA plans, can go and look at a plan star ratings and look at what is the performance on the measures that went into determining that star rating. So that's one way that this all gets to consumers. I think though I don't have an answer to this. This is just my opinion, but I think we probably as a healthcare system and as NCQA have work to do in terms of how we better get this information to consumers, because I don't know. It doesn't come up. I mean, I work in quality and it doesn't come up during my conversations, you know, at the holidays with my family. It didn't really come up a lot when my parents were shopping for, you know,
Right.
MA
Yeah.
plans. So I think there's room for us to work on.
So there's like the court of public opinion, right? There's letting people know, but there's also incentives. There's also money tied to it. So certainly somebody knows, which, you know, and right, there's always more room for more people to know. And I think the more people get to learn about how healthcare works, maybe, you know, the more it will change or improve. Let's see, there's lots going on in the chat. There is a question here, and it's a very specific question. I'm not sure it's for you, but if we have somebody on the call, it seems to be rising to the top. Michigan Department of Health and Human Services has a social determinants of health strategic plan, and Medicaid health plans and prepaid inpatient health plans have contracts with MDHHS, with MHP and PIHP only, and joint MHP and PIHP quality with hold metrics, many of which are HEDIS measures. Is this tracking with what steps are being taken to assure prospective alignment amongst and between MiHIN, MDHHS, MHPs, PIHPs, etc., so that business processes are ready? I don't think you have the answer to that, Sarah. But what you would say maybe is that this is, by instituting a measure like this, it elevates and makes these questions, makes this human infrastructure visible, right? What are we doing to align? Are we speaking the same languages? Are we asking the same questions? Are the measures being, filtered down through downstream, upstream? So I guess I'm not trying to answer for you, but I don't think you can answer that question. Do we have somebody on the call that can answer Brad's question now? And if not, we will come back to it.
So hey there, it's Lisa Nicolau. I'm the cross-sector data sharing program director for MiHIN, and certainly this kind of raises that tension that we've been talking about for a long time, which is kind of the healthcare path down to be able to aggregate data and understand better the needs, and yet that work that's going on within the community to actually address it and the data that they generate. And certainly it's not necessarily MiHIN's to take on, but certainly we are elevating those exact same issues. Here in Michigan, we have very engaged MDHHS folks who are digging into the work and trying to create that level of alignment through the CIE task force and the Health Information Technology Commission. So there's work that's going on, but this the more we kind of are able to measure, the more we are able to raise the awareness. Certainly the NCQA measures kind of bring everybody to that collective table, and it's hopeful, because what that does is it sets up the idea that we can come to a collective solution that doesn't just necessarily provide a food basket for an individual who's going for surgery, but rather raises the collective awareness as to how we choose to spend money, scarce resources within our healthcare and societal care spaces. And again, probably not like a direct answer, but there is work that's going on to be able to unify those spaces so that the business processes are set up to be able to utilize that data appropriately, and not just within healthcare, because that's, really one-sided.
Sarah, thanks. Lisa, for coming on. Don't leave. Are you leaving?
Not yet, no.
Okay. Sarah, back to you. Let's see here. Something about Gravity Project or NCA considering whether or not patients would want health plans to have access to this kind of information. If we can't even measure engagement as of yet, why is now the time to roll out this measure? How much of this information could not have been extrapolated from other equity measures we can tackle through demographics? This is sort of a why now, and what comes first, right? What comes first here? A measure or standards or convening
or funding,
right? Or funding. Look, you know what we can do? We can do things technically, by the way. Again, the easiest part.
Yeah, this is a really great question. I don't know I'm gonna be able to do it justice in the time we have left, but I think, what we can get through demographics, for example, through community level proxies for our, for various sociodemographic characteristics, can be helpful, certainly, and is helpful certainly in resource planning and understanding, what's the burden of social risks in a given community, and can be helpful for understanding, what are the resources that are going to be needed. That type of information, community level demographic information, isn't appropriate in determining individual need, and you're not going to be able to extrapolate an individual's social need based on those community level characteristics. And so I think the role of social needs screening is really an understanding, is making sure that organizations are starting to invest and think more about the individual social needs of their patients and their members, because we know those things are so integral to patients' ability to implement care plans that are provided to them by their clinical care teams and such. So I think there's a lot of really important and useful information that can be extrapolated from sort of community level demographic information, but that can't necessarily be translated to sort of the individual social need level. And the question of, whether patients want plans to have access to this information, I think is important. And this gets into a lot of important considerations around trust, not just with plans, but also with providers. There's a lot of trust building, I think, that has to happen between patients and providers and all of that. So I think it's a really important and valid question. Certainly something that we thought about, certainly something that is important in thinking through accounting for patient declination and patient sort of honoring patients' unwillingness to share this information or engage in follow-up interventions.
You're doing a great job, Sarah. Thank you. There's like 4 more minutes, and I'm going to milk every 4 more minutes. There is a question from Dan Boyle. Dan, you're asking if providers and payers use data they receive electronically from other providers via their health information exchange in their reports. So MiHIN sends and shares with healthcare plans supplemental clinical data. And then I believe those plans use that supplemental clinical data to report to NCQA. Dan, tell me more. What are you getting at? What can I tell you? What can we tell you? Is he still on? Have we lost him? We may have lost him. But I think yeah.
I can just say for the purposes of this HEDIS measure, yes. So the data that's received electronically from an HIE is acceptable for reporting this HEDIS measure.
And if you want to hear more about how it's acceptable and how MiHIN is currently working in this space around this, stick around from 11 to 11:30. See how you did that? Thanks, Sarah. Let's see, there's a lot of good connecting going on in the chat. Don't forget to look at the chat. Will NCQA look at health plan network adequacy for inclusion of home and community-based providers for the delivery of these critical services, right? We're at screening right now. What's NCQA talking about for delivery of services?
Yeah, so, this measure looks at screening and then referral to intervention. And, I mentioned we have an interest in getting to, measurement of closed loop referrals at some point. Network adequacy is obviously a huge component of that, because we know that there is a wide variety of community resource availability, and that may look very differently in rural versus urban communities, and there's a lot that goes into that. I think we haven't gotten there yet, but I think looking at sort of community resource network adequacy is definitely something that's on our radar. Network adequacy generally, not just in this space, behavioral health space as well, and other things. But I think that's a great point and something that's on our mind, certainly. Oh, I think you're muted, Joanne.
thank you so much for coming. I was talking. I said like all kinds of nice things about you, but you didn't hear it. I appreciate you coming. I appreciate your focus and your openness, your authenticity. Look, her email address is there, folks. You've got her. This is a get. Thank you, Sarah, for being here with us. For those of you who can, please stick around for the next half hour so we can start to sort of unpack how MiHIN, how our shared digital infrastructure as the state designated entity for health information is supporting the health information exchange for health plans and providers to be able to meet these kinds of measures. Thanks.
Thanks for having me, Joanne.
Come
Take
back,
care,
will
everyone.
you? Okay, good. Thanks. So Kate, let's switch over now. Let's see how many people leave. Everyone's going to leave now, Sarah. Thanks a lot. We are where we're back to. Here we are. We are back to MiHIN, social determinants of health. Look, we had a social determinants of health program, and it became very clear very fast that social determinants of health are not something that MiHIN, as the state's designated entity for health information exchange, can tackle. What MiHIN must focus on is being able to make data move cross sectors from healthcare to, let's say, community, from community to healthcare, from healthcare to schools, from schools to healthcare, from healthcare to prisons, right? Okay, like sectors. Cross-sector data exchange is what we have to focus on. But we do have a social determinant of health use case. And for those of you who are not familiar with use cases, you got to come back. We'll do a MiHIN 101. There's one on the website, but use cases are the ways that MiHIN defines specific legal, technical, clinical, business purposes for exchanging specific bits of information. So I am going to hand over this presentation now to Mike Taylor to talk about MiHIN's social determinant of health, social health screening use case and how it fits into what Sarah just talked about. Thanks. Mike.
Thank you. Just to let you know, we see the screen that has the preview of the next slide, not the full screen one.
Oh, yeah. I mean, so what, you know?
Technology these days.
Now
Sorry,
it's
give
gone.
me
Now
one
it's gone.
second.
Mike, you scared it. Hold on. Let's see, anything going on in the chat? Have we figured it all out here, folks? No, not yet. Okay, here we go.
Does this look better?
It does.
All right, so I want to give some context for the social determinants of health use case. And when we talk about social needs, when we talk about social determinants of health use case at MiHIN, we are more specifically talking about social needs screening, the entire topic of what we've been talking about all morning. And really, the crux of the context of the social needs screening is that as healthcare is waking up to the fact that a lot of the major healthcare cost drivers are determined outside of the healthcare space, we're looking for ways that the things that impact people's health and therefore healthcare costs can be addressed in ways that we haven't traditionally done that. And that means engaging sectors and engaging organizations that have not typically been part of healthcare or healthcare data exchange. Next slide. And so there's really a bigger picture of figuring out what social needs people have and coming up with strategies of how we intervene on those needs and how we get those needs addressed. But in general, screening has been a major national focus right now because screening is the entry point. It's how we know, at least in a computer system, that a person has, it's a way we can look for needs. It's a way to try to identify and surface needs potentially earlier than other mechanisms. Screening also is, I say screening is an entry point because it, from a computer system, is an easy triggering event. And by triggering event, I mean, sometimes people might have these conversations out of band, and those needs can be identified. Screening is a way to have a systematic trigger point to say, oh, somebody screened positive, now we can do something. And so that's really where a lot of the attention has been coming from. And we have a social needs screening, social determinants of health use case at MiHIN. It's been in place for a couple of years now. And if we can go to the next slide. The screenings are in fact pouring in. These are numbers just from the month of November. These are not like aggregate information. In the month of November, we received 49,671 screenings. Now note that about 4,000 of those were the same person getting screened more than once, whether it was at the same facility or not. So if you look at the third number there, number of unique patients screened, that's probably a more accurate picture of the population. 45,945 people were screened. We do see in the population of the data that we're getting that in November, 21.46% of the screenings we got had at least one positive need identified. Now that could be because there are organizations that aren't sending screenings if there's not a positive. It could be because the screenings are being given in environments that are more likely to have people with positive needs. But that is the statistic that we're seeing in the data that we are getting. The real thing I want you to take away here is that we're going to start having metrics pile up very similar to the early days of MiHIN, and we used to show, look, ADTs are really starting to ramp up, and then continuity of care documents are really starting to ramp up, and we're starting to see that with social needs screenings, and so I wanted to make sure everyone was aware of that. With the new year that's coming soon, there's going to be some changes to our social needs screening specification, and I wanted to run through those with the group today. The changes have very minimal required changes for people whom are currently submitting. Thank you. So here's a summary of the changes that are happening to our specification. There are 4 field name changes, and so those will need to be reflected in what's being submitted, but the actual underlying data of what's being submitted won't be impacted by that. That's just the name of the field that you're reporting. There's a field that was too short and didn't have enough characters, and so that field has been expanded. So anyone who was already submitting within those character fields, there's not a required change, but you're now allowed to submit more characters. There are 3 new optional fields. Optional there being the underline. So in this first year where it's on, there's no real new data required, but for example, one of the fields is a way to communicate what screening tool you're using. Again, that is optional, but now there's a way for that to be communicated so that if there's people looking at what tools are being used in the ecosystem and so on, we'll have a way to collect that. Previously, we did not support Canadian postal codes. It had to be a US 5-digit zip code, 5 or 9-digit zip code. So now we accept Canadian. And the last thing is that the domains that can be indicated in the file have been updated to match the Gravity project. So that's the summary. I'm now going to open up the spec and show that in more granularity. And so I have open now the file specification for the new that will take effect in 2023. So there's as a recentering around what our specification looks like. There are two different formats that you can submit to MiHIN. There's the previous file format that had been used during the State Innovation Model, or SIM days, that has 15 questions that everyone participating in the SIM project was using as their screening. And we've continued to accept that file unchanged. And that is going to continue to be the case through this year. And when you're looking at the specification, anything that says version 2, that was the SIM file. And there's 3 tabs there: the detailed, the template, and the example. The detailed gives you the individual field specifications. The template just gives you something to go off of with all the headers. And the example has those headers with dummy data in it. For the version 3 file, where the specifications are, the updates are from this year, we have the same 3 tabs. And if you go to the detailed tab, you'll see the changes actually highlighted in yellow from the year before. And there's 2 different columns, so you can compare what was the previous data element and what is the new data element. So you can see some of the names changed to parallel the changes that are happening in our ecosystem, where we're not only focusing on physician organizations anymore, we're opening this up so that others can be screening as well. So that was changed just to source name and sourceoid. Gender was changed to sex as another alignment with standards more generally. Zip code was changed to postal code, in accordance with the fact that we're not only accepting the US zip code, but also the Canadian formatted postal code as well. Then here's where the domains have been updated. There's not a comparison to what the previous year was, but it was just adding some domains that had not been previously included. The answer field has been expanded to 512 characters. Okay, so the need identified is the only item that could really be confusing. It looks like it's been changed to required. It was in fact always required, and you were not able to submit without having this field populated, but in the spec it was listed as, I don't know if it was listed as optional or conditional, but it was a mistake in the previous version. So this now is reflected appropriately as required. And these are the new 3 fields, 2 fields to indicate the screening provider. And again, these are optional. And the last one being a way to identify the screening tool. The last thing I want to point out today when we're going through the spec is that there is a final tab here. These are the tools that we know of that have LOINC codes and the LOINC codes associated with them. These parallel the same tools that are listed with the NCQA measure. So this can also be a cheat sheet for that if you're needing one. But this is here for your convenience. So with that, I suppose we're ready for questions, or Joanne, if you have something.
I mean, I always have something, but I would love to open it up at this point to our audience. What do you think? Why are you here? What can we tell you? What are you here to find out? Make this time worthy for you. What have we forgotten? What have we missed? What are you concerned about? How does my hair look? You know, all kinds of important things. Health leads, Mike Taylor, health leads on your lists. It's an approved screening tool per NCQA.
Okay. I would love to add it to this spec. I didn't realize that there was one we had missed. Sorry.
Oh, Teresa, you just changed the course of history at the download. Unbelievable. Thank you. Sex is now preferred, not gender at birth, from Bruce Kelly, Mike Taylor.
In accordance with the
Is this like real Soji?
yes, the real SOGI efforts that are going on, MiHIN statewide and nationally. Yes, I think that's the preferred term. I'm not the authoritative person on that, but that's my understanding.
Any other burning questions? Because if not, I did want to tell you, what's Mike's email? Mike, will you put it in the chat, Mike? Write to Mike. What about zip +4? Zip +4 for postal code, Mike?
I will go to it. I'm pretty sure we're looking for the -4. Yeah, we're looking for a 5-digit US zip code.
Bruce, is that is that a problem?
Good question.
Or is it just something like we just want to be specific because this is how data moves by standards, right?
Yeah, I'm a technical guy, so
Oh, Bruce,
details.
I love it.
So,
Who can?
I'm not sure if we're sending zip +4 now or not, so we'll just have to tweak it to drop that if we do.
Is that the way it is for like health directory too, Mike Taylor?
For acres, it is this way. Yes, it was previously just looking for the 5-digit. It is now in the 5 or 7, matching what is being submitted for acres files.
Okay, maybe people don't know. Health directory, acres. Acres stands for Active Care Relationship Service. It is MiHIN's way of providing context around any one individual. It's how we match the right Mike Taylor to the right Mike Taylor and all of Mike Taylor's attributes. Mike Taylor's, his world, digitally. Wait, hold on. I just wanted to say something else. Who can, okay, so I don't know how to pronounce your name. You'll have to forgive me. Shahui? Who can or are required to submit the SDOH data to MiHIN? So this is this is a very interesting question. Number one, required. I don't think, stop me if I'm wrong, Mike Taylor. Who is required to submit SDOH data to MiHIN?
There are incentives from Blue Cross Blue Shield today for, I believe it's officially recognized POs to submit data, but it's not a hard requirement. I think it's an incentive. And beyond that, I don't believe there is a requirement. Though we would love anyone who's not under that incentive to still participate.
Who can submit SDOH data to MiHIN? If you could, Kate, let's go back real quick right now. So can you go back to that chain of trust slide, Kate, if you're still with us?
Yep, give me 1 second.
Sorry, I'm throwing things out there. But I said it would come back up, and I just want to try and be clear. Who can submit data to MiHIN? Right now, covered entities and those with business, those who are in business associate agreements or have signed business associate agreements and have signed the legal agreements to work within MiHIN's use case structure can participate within our network. Is that about as clear as mud? If you don't understand, tell me more. This is how data can legally, technically, privately move under HIPAA right now for MiHIN.
Can I ask a question?
Lisa, you're asking me?
Yeah, I'm not asking you. No.
Oh, okay.
Sorry. I am curious to know. Sorry, I'll get my stand up here. I'm curious to know the person who asked the question initially, what organization, sector they represent, and your intention of being able to ask that question. And feel free to come off mute and just kind of speak away if you can.
On the
Is it-
spot, Lisa. Not
Sorry,
sure.
I'm really bad at calling people
On
out.
the
Or
spot.
drop it in the chat and just kind of tell me what sector you represent, and that's an important question.
It is.
Well, I was speaking, but I forgot to unmute myself.
Hi.
So I'm Shahui. I was asking because I was thinking about Michigan Medicaid, because the state is also collecting the SDOH data. I'm wondering if the POs are any of the Medicaid plans are involved in submitting this data to MiHIN.
So, so you bring up two really good things. One is the state itself is a very big entity. When you say the state is collecting that data, what organizations specifically are you talking about? Are you talking about Michigan Medicaid plans, the health plans?
Well, the Michigan State, they ask, Medicaid management unit is asking, the health plans to submit SDOH, or at least screen people and submit the results of the data to the state. So I wonder what is the relation between MiHIN and the state collection?
So that's a really great question. You raise things that are kind of coming up multiple times over. Like there's requirements across the healthcare industry, whether that's from like Michigan Medicaid plans, whether or not we're incentivizing through commercial payers for kind of moving this data around. And what you're really talking about is that melding of all of those different processes together so that we're coming down to a single data set that helps to meet all of those different requirements. So I know that Molly and I think maybe Teresa from the state are on the call, maybe. And I'm wondering if that is a good question for the state. And if Molly or Teresa want to help me field that so that I'm not kind of putting my foot in my mouth. Joanne, can you see if Molly or Teresa are still on the call?
I don't see them, but
Okay.
I want to, I think that we should come back to this question in some way, like with a follow-up to, to all of the people who are here to have, to have witnessed it. So we do follow-ups. And certainly we can come back around to it when we have our partners here to answer with us at the state.
And I'm wondering because, part of our role within this is to be able to make sure that we're elevating the stakeholders who come to us and ask these questions. If we individually are not the right people to answer that question, we elevate those questions and those barriers to the right people within the environment so that it's at least a known problem. So I'm wondering if, and I'm going to really massacre your name worse than Joanne did, so I'm not even going to say it. If you want to email me, if I drop my email in the chat, can you email me? And that way it allows me to say, hey, this person had this question, we can elevate it to where it needs to be. Because you raise a really important question and an important factor as all of these different entities spin off and have their own processes and data aggregation. So I think it's great that you raised it.
Thank you. I'm just concerned about duplication of data collection.
So are we,
Yes.
very much so.
Yes. like along those lines, guys, look, I want to tell you about our next download because it's going to be major, because what we have at the next download, and then I'm going to come back. So for our next download, mark it in your calendars. Not sure if you've heard, but MiHIN has convened some of the social care platform vendors, okay? So these are the systems that make it technically possible for places like libraries or community-based organizations or schools or, or jails or AAAs to be able to screen and to refer for social care. Care advisors, Care Convene, Find Help, formerly Ambertha, Holon, PCE, Riverstar, Unite Us, WellSky. These are the systems that are making it technically possible, right, to share that information that even NCQA was referring to. We have them all committed somehow to working together, even though they are competitors in this field, working together and committed to trying to find a path to make it so that information can flow between their networks, so that if somebody has been screened at a library in a system and in the Find Help system, and we find that there is a provider who is outside of that system who is working in WellSky, we would like to be able to get the information of need, the screen, and the referral over and between systems. The ability for systems to talk to one another broadly by standard-based by standards is called interoperability. So we are working on interoperable referrals, and we have these people coming to the table and saying that this is how they want to work. And libraries should come, community-based organizations should come. Ask these vendors, ask these systems what's technically possible, how the information is being shared, how they provide consent. The next download, there are 175 people signed up for this one. We want to see 500 at the next one, guys. Tell everybody. There was, Lisa, I wanted to just really reiterate this question from Wortkamp, Wortkamp, about libraries. And again, remember, we were talking cross-sector, like what does libraries have to do with healthcare? Well, guess what? A lot of people use libraries for care.
Yes.
To your point. And how are you supposed to share that information? For what purposes? Where does the information go ultimately? Does it make it all the way to NCQA?
Yes. And, the libraries question is a really great question. And that's part of kind of the avenue that we're using to be able to better understand what we really have to be able to do, and what is like not a barrier, but a challenge to be able to kind of do this is understanding how do we treat data that is generated within the community so that it is, governed the right way, and is that HIPAA data? Could it be HIPAA data? Should it be HIPAA data? What's the predominant thinking? So we are in the process of melding that so that the health information data, the data that is generated within healthcare, follows HIPAA. How do we incorporate in, for the purposes of health equity, for the purposes of meeting people's needs, and for data analysis that drive decision making? How do we bring in that data generated within community in an equitable way? So that is on our field of our radar. We want to be able to get to that so that data is not siloed and just being one-to-one, let me link you to an individual, but then being utilized across the ecosystem.
We are like 2 minutes before we have to end. I would like to talk about this for the rest of my life until I die. However, not everybody can do that with me right now. Melissa Gary, Lisa, we have got to get back to Melissa Gary. She's asking about, what about organizations that are on multiple EMRs, CBOs? How can they possibly participate? Like, will the CIEs be able to get MiHIN the information? These are the questions, Melissa, and we are working our darndest to come up with paths to make it possible to reach whatever goals your goals are. If your goals are just to get people served, then let's see how you can get people served. If your goals are to share this information in order to create equity, in order to push plans, to push providers to think about, this type of care, then do you share that information? Is it your information to be shared? So many great questions. We are just at the beginning here, but we are at the end of our time for the download. Thank you for coming. Please come back. It is our pleasure and our privilege to be working on this for you and with you. See you next time.
Thank you.